Okay, thanks. We talked about it, but I didn't actually push the button.
Thank you, Ms. Thorpe.
Okay. All right, so. Any other, because once I start the PowerPoint, it's hard to see. So Nozomi and everybody, just like I said, don't worry about that you're not being counted, because I see there's 42 people here, so, okay.
Thank you.
Let's see. All right, can everybody see the PowerPoint?
No, we can't see it.
Are you supposed to be sharing your screen, or are we supposed to be looking at it on our own end?
No, I'll share it. Let me see. Share screen one. I want to do share screen one. Now?
Yes.
Yeah.
Okay. All right, and don't be afraid to say something to me, because with 3 screens, I can't see everybody. So what I thought we'd start with is talking about giving birth, because that the whole, and I'm gonna stop saying through my lectures. The exemplars for the week are the labor and delivery, a normal labor and delivery, vaginal birth, any indications that you would have for C-sections. And then we want to talk about pain relief in relation to what someone's feeling while they're in labor. A little bit carries over to a C-section, but we're specifically gonna, in the pain PowerPoint, they talk about the non-pharmacological pain relief in labor also. So I'll direct you to that as we go. So this week, these are the objectives. We're looking at what is the labor process, what is false labor versus true, somebody in true labor, the different stages of the labor, in the 5 Ps of labor, and then going into nursing assessments for both the mom and the baby. Now, that being said, your assignment, the ATI assignments that were there, I think it was a vaginal birth, epidural, and a C-section, correct? For the ATI video ones?
It was like stages of labor, or stages of, labor, and then the epidural, and I believe C-section.
Yeah, those were really nice, actually. I was like, wow, they watch these, they're going to have a pretty good grasp. But I mean, those of you who are in OB right now are seeing this, correct? I mean, if you've already been in L&D, you've already started to see exactly what they've been doing in those videos. But it's hard for you guys who aren't there yet to get the visuals. So those are really good visuals. You watch those, you have a really good idea. When we're talking about new nurses coming into labor and delivery, it can be a hard area to be in. I remember my first, mind you, this is over 30 some years ago, I started as a new grad in labor and delivery. And I never had any kids. This was all very new. We didn't really have much labor and delivery in our clinical even. So started as a new grad. The idea of constantly hearing people in pain. In those days, they didn't do epidurals and the spinal blocks and all of this stuff for pain tolerance. It was like women either got IV pain meds or we gave IM injections, and you really worked hard on the comfort measures and learning how to massage and teaching patients to breathe in order to get the mom through the labor. Personally, for me at that point, I thought it was, I don't know if barbaric's a word, but it just felt like there's got to be something more. So new nurses going into this and experiencing all of this, it can if you don't look at it in the right way, or the more of a positive way, it can leave you with, there's no way I ever want to work in labor and delivery. So, and I think we all know, actually, I think Mrs. Diamond is one of those people that is like, no way, no how, I never want to do labor and delivery. But every area has its hard points and positive points, I guess. So, labor and birth affect the physiological systems of both the mom and the baby. So these effects are most striking in the maternal reproductive system and in relation to the fetal and neonatal oxygenation. So basically, during this labor process, you're not just thinking about, oh, here's a mom in pain and she's going to give birth. You think about what, yes, she's in pain. Why is she in pain? She's having contractions. What are those contractions doing to her physiologically and to the baby physiologically? And as we go through this, you'll realize, wow, why we pay attention to how often contractions are, how long contractions are. Because as you think about it, you realize the effect on the baby is that he's not getting, or she is getting oxygenated blood for brief periods during those contractions, at the peaks of those contractions. A typical contraction cycle consists of you can see here where the contractions going up, they call it the increment. The increment gets to the peak, and then you have the decreasing or the loosening of the contraction. And here they're showing you, this is when you're measuring, and those of you who have maybe seen this in L&D, they call these Montevideo. If you're looking at a monitor strip, this from this point up here is Montevideo units that you would be measuring. So when they say, typically you want to see 240 Montevideo units in a 10-minute time cycle to say, yes, this person is having effective contractions that should be changing her cervix. Other than that, you start looking at how long are the contractions. Typically, they should be 60 to 90 seconds at the most. 90 is getting out there. And you need to have this relaxation period in here. This is the way I think of it. This is where the infant gets to take its breath, okay? If you don't have this, or this level stays up here, you have a baby that's going to get compromised eventually. You might not see it right away, but if they labor like that for a long period, you're going to see that the baby will suffer. So the interesting thing about the uterus is that it actually works by, this top part is actually the part that is contracting and pushing the fetus down. The lower part of this really doesn't give any kind of pushback at all. This lower third is, as this pushes down, it basically, its job is to give way to let the fetus deliver. Okay. This is a good indication, and I don't know if they talk about Bishop's score. Did they talk about Bishop's score in the ATI books? Do you remember? Oops.
Yeah.
Yeah. So with the I'm going to put it over here so I can see you guys a little better. With the Bishop score, basically your part of the score is scoring the cervix. Okay. Here is a prima gravida. What is a prima gravida?
First time pregnancy.
First time having a baby. Yes. And a multigravida then is someone who's had a baby before, even if she's just had one baby. The cervix of a primate, for short, is usually this thick, and I always use my hand to show students or when I was doing new grads, the thickness of your hand, between your thumb and your index finger, if you feel that thickness, that's how thick, and that's kind of the way the cervix feels when you're having your first baby. As the cervix thins out, and it's called effacement, the cervix becomes really thin. And it's when you open your hand up and you have the, between the thumb and the index finger, how thin that skin is right in there. That's how thin the cervix gets. You have to have it get that thin in order for dilatation really to occur especially with a first baby. It'll get, so if you keep feeling, the doctor will say, yeah, she's still not all the way effaced, or she might be 80%. Well, there's something going on. The pressure of the presenting part is not putting enough pressure on the cervix to get it to thin out, and she'll get stuck. There's something else going on why it's not happening. That being said, with a mole tip, you may not see it ever get that thin again, but it'll start out, see how thick this one is? It'll start out where she might feel 1 to 2, we'll say 80%, or actually 1 to 2, maybe 50% effaced to start out. And then typically the labor goes faster for the mole tip. So there's different responses to physiologic responses to labor. Okay, so when you think about it, for the cardiovascular system, with each contraction, the blood flow to the placenta gradually decreases. So it's like this big sponge that's getting squeezed. So that blood goes back out to mom's blood volume for that short period, right? It's just a temporary increase that you'll see it in her blood pressure, and it might decrease her pulse, right? When you think about somebody who's now hypervolemic, what are we going to see on blood pressures and pulses and stuff? Do you see how that goes? That being said, so then between that the contraction relaxes, right? So the blood flow goes back into the placenta, and the baby gets its oxygen, and everything, has time to recover, and then it'll happen again. There's different situations that occur that, especially with a term mom, this is a 38 to 40 week infant who could be anywhere from 6 to 7 pounds to 10 pounds. And if she lays on her back, think about when a woman is that pregnant, right out in front of her, lays on her back, what that does to the return of blood back to her heart and lungs and everything, right? It's going to have a dramatic effect. So what is that going to do to mom? What kind of vital sign do you think you'll see?
Drop her blood pressure.
It'll drop, right? Supine hypotension. Mm-hmm. So you'll see, and just to carry that a little further, what do you think that does to the baby?
Puts the baby in distress.
Sure. Why do you think, Brittany?
Are we talking about the vena cava syndrome when she lays down?
Yes. Yes.
I mean, you're dropping the mom's blood pressure. You're dropping nutrients, oxygen, anything that's going to and from the baby.
Right. Right. So the baby's going to get into some distress. So that's for me as a labor nurse, a labor and delivery nurse, to walk in and find a term mom flat on her back, it just kind of sends chills through you. So the first thing you do is help her get positioned on her side. Brief periods, where she's kind of got her hip off being flat on her back is okay, but one side or the other, proper legs, changing positions is really what you want to see. So let's think about respiratory wise. What is it doing to her respiratory wise? What would you think is going on during the birthing process for mom?
She's increasing her respiration.
Yeah, her contract, I mean, she's breathing faster because she's in pain, right? Why else would she be having shorter breaths or breathing faster?
The pressure of the baby on her
Yeah,
dad.
her lung capacity is decreased because she's got this big uterus pushing her lungs up, right?
Mm-hmm.
So yeah. It's easier for her then to hyperventilate. So extremely important to, if you start seeing, you have her coming in and she's like, you have to teach them the breathing. You remind them, take your big breath, relax, and get her in. And I have had them breathe in a paper bag before. GI wise, what do you think is going on with her? Now we're talking a woman now who's in labor. Have they found that women are really hungry when they're in labor?
No.
What do you think?
I wouldn't think so.
Constipated because they have all that pressure down there.
Sure.
They're not very hungry.
And while they're in labor, I think of it almost as a little bit of a fight or flight response, right? Because it's extreme. I mean, they're not focused on taking in food. They're focused on, delivering this baby. Their whole body is focused on this. That being said, it used to be that we had docs, I worked with one doc that wouldn't even give them ice chips during labor. And it just seemed so counterintuitive. Here's this woman who, yeah, you're giving her IV fluid, but she's thirsty. She's, she has these needs. Now you'll find that it took a little bit for me to get used to it, but you'll actually find that they'll feed moms small, if they're in kind of an early labor, they'll feed moms small little food, like maybe, I don't know, maybe like oatmeal or a little bit of a sandwich or some popsicles. They'll give them food during that.
Can you name some hospitals? Because that would have been nice.
Yes, yeah, they do. They do. And it kind of, when I first started back just doing, as an instructor doing more L&D again, I was like, it felt funny seeing them get trays, but it actually is really nice for the mom. It makes it, for me, it seemed less, and I know the word's not right, but kind of that barbaric, where here you got this woman who's in extreme pain, you're not giving her pain medicine, you're not feeding her, so it's nice. It's gotten much better. How about when you think about the urinary system?
I think they have urge to go void. They have a pressure on their bladder, so they feel like they want to go to a bathroom often.
Right. That could be, and then what happens is we give them a regional pain management, like an epidural or a spinal, and now they don't even know that their bladder is completely full, and we've pumped them through with a bunch of IV fluid. So that is why during labor, as well as after they deliver, paying attention to how full their bladder is extremely important. And that is why most of the time, I know at Natividad, I don't know if they do this at Memorial now, but Natividad pretty much puts a Foley catheter in them when they do their epidural. And what that does is it helps keep the bladder empty because they don't know they don't have that sensation. It also, what do you think it's doing when you think about that baby, that fetal head pushing down, trying to come out during the contraction?
It gives it more room.
Gives it more room. Yeah. If you have a big full bladder, the baby's not going to be going anywhere. So, and then you have, so that's why then you have to really make sure after birth that this mom, you've now DC'd that catheter, that this mom is able to empty her bladder. I had this wasn't even while I was working in L&D, it was my neighbor years ago. She first baby, had her epidural, everything went fairly well. She got home and she was just in excruciating pain. And I was going over to check on her and I just could not figure out why she would be in this kind of pain, right? But I didn't know her that well. So I was just kind of, it was more like, okay, well, let me help you with different things. Well, come to find out, she had not been emptying her bladder all the way. And she had, I think I remember her saying like 1,000 mLs that they emptied from her bladder. She ended up having to have a catheter, a Foley catheter in place for like 3 or 4 weeks so that her bladder could heal from being stretched like that. So it's extremely important to have that paid attention to.
I have a question.
Yeah.
You talked about at the same time as giving the epidural, wouldn't they consider doing a Foley with an epidural because they don't want you getting up and going to the bathroom after getting an epidural?
You know, there's different philosophies on that, but Brittany, I have seen them at Natividad at least putting like you're saying, putting the epidural, putting the Foley catheter in at the time they're doing the epidural.
Yeah, that just makes sense to me.
Doesn't it? It does make total sense.
I just wouldn't feel comfortable sending my patient to the bathroom or trying to get them to void on their own after giving them an epidural.
No, the only thing though that I mean, if they can, they're not going to have as much sensation, but some patients, the epidural is such that they can still move okay. The movement sometimes is good for them, right? If they're stuck in bed all that time, sometimes getting them up, right, and maybe just over to the chair, but you're right, sometimes getting them all the way over to the bathroom is another whole story. But yeah, they do put the catheters in now.
Okay.
I don't know again what they're doing at Memorial. And then the hemopoietic system, I think you've probably read this, but basically that their whole blood volume is increasing while this pregnancy is from the start, their blood volume increases. When they go to have the baby, an average blood loss, so think about this, is 500 mLs. That's what they say is an average blood loss during a vaginal delivery. And the mom usually does fine with that because of that fluid volume influx that they've had during their whole pregnancy. Moms usually do really well. You don't see much in the way of any kind of symptoms, or even in her H&H, it doesn't change much. You know, we're happy with 10 to 12 for a hematocrit, 33 to maybe 36, I think is kind of a range for H&H. And then paying attention to platelets, obviously, because you don't want them getting into problems with not being able to clot. The white blood count might go up. Usually, I think in the book, the things I've seen is 14 to 16. I have seen 25, as high as 25, and them not having any kind of infection going on. The clotting factors like fibrinogen are elevated and continue to be elevated during labor and delivery. The fibrinolysis, the one that that's used for the clot breakdown, is actually decreased during labor, so that decreases during labor so that the woman will clot after the placenta is delivered. Okay. You can see although the increase in these clotting factors and the decrease in fibrinolysis protect from hemorrhage, it also has this combination of you worry about mom getting a venous thrombosis. In the lower, that's why we check for the Homan sign. I know Homan sign isn't really the technical term anymore, but you're checking their lower limbs that they don't have a clot lodged in their calves or anything like that. So the fetal response to the birthing process, basically the baby has been inside and getting all of its oxygen and nutrients from the placenta. The placental circulation exchanges the oxygen, the nutrients, it gets rid of the waste products between the mom and the baby. And where does that happen? Do you remember where that happens? Do you remember those, what there's called, their spaces? What is that called? Do you remember the intervillous spaces? So they're little areas between the mom's uterine wall and the placenta, and all of that is going on in that space. So during the strong, I already said this, during the strong labor contractions, the mom's blood supply to the placenta pretty much stops as the spiral arteries supplying the spaces are compressed when the uterus is pushing that baby down. So most of the placental exchange occurs during in between the contractions, during the rest periods. Usually the placental circulation is enough during that rest period, enough to keep the baby healthy and reactive during the whole labor, and everything is fine. But you can see that if you have a mom that maybe has high blood pressure, that for some reason the baby is small, maybe she got some sort of virus during her pregnancy, and now they've noted that the baby is actually IUGR, intrauterine growth. And I know what is the other, instead of the retarded, it's restricted, intrauterine growth restricted. Those babies are at extremely high risk. You can see, if you think about it, during labor, during this specific time. So now you have this little guy, maybe the placenta is so, it might even be getting kind of old, and you push that placenta down, and the baby was barely getting really a great amount of nutrients already. And now you've put that baby, each contraction could be worsening that environment for that baby. So that's why we watch these moms so careful, and there isn't the tolerance to let the baby push through that labor. If they start seeing with these little babies and these moms with high blood pressure, they will do a C-section sooner than later on these kind of babies. It makes sense, right?
Mrs. Thorpe, would that be the same thing, like that intrauterine growth restriction? Would that be the same thing as like, or related to whether the mom has like a 2-vessel cord?
Yes, it could, because that's going to decrease the blood supply to the baby. When you think about it, also a 2-vessel cord, there is some indication that the baby will have some renal issues also. So that's one of those indicators. Oh, there's only a 2-vessel cord. We need to do maybe a renal ultrasound on the baby before they go home. That kind of stuff. Sometimes it's fine, but
that was a circumstance the other day with that one really sick baby in the NICU that was born at, like, I think it was 32 weeks.
Yeah.
Brittany, I think you had the mom, right, Brittany?
Yeah, I had the mom.
And not only was he born early, but it was determined that she had a 2-vessel cord with him.
Oh.
We're just thinking about that.
Yeah. So it's probably good that little one was delivered. And how big was that baby?
Like 3 pounds.
Yeah, I think he was
Okay.
3 pounds, 2 ounces.
32 weeks. That's actually not a bad weight for 32 weeks. So yeah, but good example. So as far as fetal cardiovascular system, again, most fetal heart rate runs about 110 to 160. Doesn't mean if you have a baby that's hovering in the 100s through the whole labor and everything else looks great, that baby is having any problems. It just means that's the average range, okay? In the preterm baby, you may see the baseline be a little higher, and it just has to do with, this is a little preemie that's smaller and the lungs aren't fully developed, and but so that's a norm. Preterm babies will have a little higher baseline. For as far as the pulmonary system on the babies, they're fluid filled while they're inside. In this fluid, actually, they do breathing inside. Those muscles and diaphragm, everything's practicing for breathing in the little ones. And then as the baby gets ready to deliver, the idea is that this fluid in the lung field starts decreasing a little more, and then at delivery time, basically the infant delivers, and the lungs, that fluid in the lungs, some gets pushed out with the actual vaginal delivery. Sorry, my dog is here getting sick. Oh, sorry. Some gets pushed out with the actual delivery. Oh, shoot. I'm going to let him out. Just 1 second. You guys go out. Sorry. And then the rest should absorb. With most term babies, that just with crying and moving, it absorbs into the fluid volume, and it's fine. But you can see how a couple of things could influence that. C-section babies may have more lung fluid still, even if it's a term baby, when they deliver, because they're not going through the vaginal canal. So you might find a C-section baby would have a little higher risk of some just kind of more that rattly lungs right at first, but usually they do fine. If it's a big term baby, they clear it. And then as let's see what else with this. I think so. That's it for term babies. That's just it goes away. So this was actually one of the objectives, right? So it talks about the 4 major factors, the 4 P's that interact in a normal childbirth vaginal delivery. And they are the powers, the passage, the passenger, and the psyche, okay? The 2 powers of labor are the uterine contractions in the mom's pushing ability. So that's the powers. The passage, sorry, let me go. The passage is the natural mechanisms of labor. I'm going to just go through this because it'll be clear. So the passage for birth of the fetus consists of maternal pelvis and its soft tissues. So basically they're saying, how clear is that passage for this baby to come down, right? What does the bony pelvis have to do? How much soft tissue is there? How much really muscle around the pelvis also? I've seen really athletic women have problems in labor because they're basically their pelvis was never really did what it needed to and relax. Remember that relaxin hormone basically that helps the pelvis, those ligaments and tendons to relax so that the baby will come out. So the true pelvis has the 3 divisions: the inlet, the mid pelvis, and the outlet. And we'll go through that. I want to keep on target here. Let's see, 1150. Okay, well, you guys, I'm going to give me a few more minutes and I'm going to let you go to break, and then we're going to come back and probably do the case study. So, but this is my PowerPoint right now. And I did give you, I think, a basic one that has a lot of this stuff in it, but I can post this one if you need to too. Okay. So basically back here, we're talking about the pelvic divisions and the measurements. So when you think about it, all of this makes a difference in that little baby coming down, right? So at some point, if you have a 10-pound baby, these bones aren't giving way, right? So when we talk about the passenger, we need to think about what position the baby's head is in. Is it the baby's head or is it the little butt coming down? The fetal lie, meaning is the baby transverse? Is it so transverse, diagonal? There's all sorts of lies they could be. The attitude, the presentation, and the position. So when you're thinking about the baby, and we assess the fontanelles and the overriding sutures and stuff for this little baby when we're doing our newborn assessment, you can see here the anterior fontanelle should be the bigger one. It's diamond shaped. It's usually very easy to find. Sometimes this posterior fontanelle is a little harder to find because it's very small sometimes. It doesn't necessarily mean anything's bad as long as all of these sutures are not connected yet, are not fused yet. You can see, think about this, looking at this baby's head, why these sutures need to not be fused. If you have any fusing that goes on, the brain cannot grow. All right, and the baby will get into problems. But you can also look at what diameters of this baby's head are going to be the easiest to get through the pelvis, right? So look here, if we have a baby that's coming full frontal occiput, so the baby's just coming straight down, on a term baby, it's the widest diameter. Here you have the anterior fontanelle. If that's the presenting part, you can have that's less, okay? So it just gives you an idea. Lie, again, is where the baby is lying, okay? This is great. This isn't so great if you want the baby to come out. Sometimes that's why they end up a C-section. And attitude is basically the fetus in relation to the body parts to each other. So here, this baby is flexed inward. So he's where he needs to be, so that when this head starts coming down and he is starting to turn and putting up his head, he's going to come out, his shoulders should do fine. This little one is going to have difficulty, right? He's not, you go to do a vag exam on him, you're sticking your finger in his eye on the mom, okay? This is not most likely this mom would need to be C-sectioned unless they could turn the baby somehow. So here's some different cephalic presentations. Just take a look at them. And it just gives you an idea of what happens as the baby's coming down. Okay, what's the different positions? Here's some breech positions. Babies can deliver breech. It's more difficult, and I just real quickly tell you the reason why it becomes difficult is you can see that this little butt is a soft tissue, and as it's coming down, it may very well deliver, okay, but then you get up here to this head, this cervix may not have dilated all the way. So now you have this head trying to come out in a cervix that's not dilated. And there have been some really bad things that I think about, but I'm not going to tell you about what that can happen in those situations. So this is just having to do with trying to figure out, and honestly, it is hard because sometimes a baby has a lot of capit, but just figuring out, okay, is this baby LOA or is it LOP? Is the occipitus posterior or is it anterior? That's just what this means, okay? And here's some different presentations. Okay, I think let's take a quick break. It is 11:56. Let's say, can we take 10 minutes and come back?
Okay. Sounds good.
Okay. Okay. All right, everybody back? Let me just do a few more slides and then I want to get to our case study. All right. So one of the P's then is psyche, sorry. And it is going to be a crucial part of the childbirth process. So this mother is feeling anxiety, fear. She may be exhausted because she's been in prodromal labor for 2 days. You'll hear some moms say this. Her whole system, she's got catecholamines that are being pumped out because she's so anxious. And she's afraid of the pain that she's going to start having. All of this, when you think about the whole interrelationship, what that does to the birthing process, is mom relaxing enough so that she actually, the contractions can relax? Let me back up. The contractions can actually do the work they need to do. It's like us, if our muscles are continually tense and you're all anxious, how effective are you in lifting a barbell, right? I mean, it doesn't work as well. So think about the 4 Ps, the power, the passage, passenger, and psychic, and how they interrelate, and how this all comes together in the mother bearing down and pushing this little baby out. And then on top of it, the whole psychological part of this for this mother, however way she's looking at the pregnancy, right? Does that make sense, guys? Yeah?
Yeah.
Okay. Any questions? So this part of the whole labor process for nurses is really a key to how this mother is going to get through this process, right? And we can be a key to helping this be a positive experience, or we can also be that person that interferes with her having a positive experience. So we have to be that in these situations, when you keep talking about us nurses, we're advocates for our patients. During this whole process, it is extremely important that, starting with that labor and delivery nurse, that you are an advocate for this mom and her family. Mainly this mom, right? It's her right to have this delivery the way she wants it. It may not fit in our box, our little, what we see as a normal delivery, but for this mom, she has a different vision. So we have to be open to that, as long as she's safe and the baby is in a safe position, and that line isn't getting crossed. You have to be flexible. You have to be able to change and understand where this mom wants to be. Take into the fact, again, going back to her individual values, intercultural values. And again, remember, just because someone's part of a culture or race, don't lump them in, everybody into one thing, right? Right? This person could, she could, from her culture, could give you clues into how she wants this birth to be, or what her expectations and everything of this birth experience should be. But it could also not be. Your tool, the diversity tool, I think, Shannon, you got to do the diversity tool at Natividad on a woman who's just waiting around to have her baby because she's got other stuff going on. But I mean, share how that tool went for you.
It went really well. She was she had a same-sex partner and they had tried multiple times to get pregnant. She's a diabetic with severe preeclampsia. She's at 32 weeks and they're trying to get her to 34. They're not going to let her go past 34 weeks due to her pressures and the risk for the baby. And so I just sat down with her, kind of went in and, told her what I needed to do and, thought that since, she's just sitting around, if she had some time and wanted, to kind of hang out with me, I'd be happy to talk with her. And it was nice to kind of get her and her partner involved in the conversation and just kind of talk about their values and, what ideas they had for, their baby. And, we kind of talked about a number of things, not just, the specific questions. We kind of came up with our own topics and conversation. And it was just nice to have that experience and to be able to speak with somebody. It would have been a little bit different, I think, and a little more challenging if the person didn't speak the same language as I did, because I think when you have an interpreter involved, sometimes the information doesn't get relayed exactly the way that you want it to, and there's always that lapse between like your facial expression, like it flows better when you can speak the same language as the person, and it went really well.
Yeah, good. Good. You can see how that information would help you if, as the labor nurse now, you had this mom. You come with a whole other picture of this mom and her challenges, and as a couple, their challenges, and what family unit they're going to form. So good. Let's see. I am now going to switch to because we're not going to have time if we don't. I'm going to over to, how do I get out of here? Let's go to let me get to, I'm going to go to the case study, okay? So in the assignment for the case study, and I believe we had actually closed it so that we could do it this way. So I just published it. And I am going to go ahead and open the Google Doc. And if this works, this will be really nice. Let's see. Okay, we'll go back to those questions if you guys have more on that. So can you all see this? It looks like people are signing in.
Are you sharing your screen right now, or?
Oh, I guess that helps. Okay, let's see. Here we go. There. All right.
Yes, we can see
but
it.
So everybody can see it and you're able to write on it?
Where do we find access to this?
In the chat.
It's what?
I put the link in the chat, but it's also in the module.
Oh, it's in the chat. Okay. Oh, thank you.
Oh, okay. Thank you. It was in the module too, but probably the chat is easier to get to. Yeah.
Yes. Thank you.
Okay. So what we're going to do is we're just going to start this. Okay. And again, this is taken from a book of clinical case studies. And sorry, I may have to have you guys kind of take over if they're going to keep doing this. Let's see here. Oh no, you can still see. If I do video off, can you still see the form?
Yes.
Okay. Okay, so this is, you're the charge nurse and you're working in labor and delivery at the local hospital, and DH is your patient, and she arrives reporting that her contractions are feeling somewhat uncomfortable. You take her to the triage room, and you have her change into a gown and you begin to do her assessment. What do you think are the 4 questions you want to ask, and why?
You want to know if she's had any leakage or drainage of any kind, just to see if her water is broken.
Good. Okay. Somebody put gestational weeks, right? So for this mom, it might be, you might ask, when is your due date? Right? And then she may not know in weeks what that is, but most moms, there's a lot of moms that know exactly what that is. Alfredo, you're writing history. What kind of history?
Like if she ever had a abortion or preterm birth before, stuff like that.
Yeah, preterm that's a great point. Who said that? That was Alfredo? Alfredo, that's a great point. Because if this is a mom who comes in and says, and essentially you figure out her gestational age, the baby's gestational age is 28 weeks, and she's come in with some contractions, then, and she tells you she's had a preterm labor before, that should send up a lot of red flags, right? That should be like, okay, this is a person we need to really assess and get the doctor to come in and assess her cervix.
Right.
Pardon me?
No, I agree. I said right.
Yeah. Okay, good. So yeah, you everyone kind of hit on the ones. You want to know some sort of history. How many babies has she had? What is her water broken? Is she her membranes ruptured? Is it her first pregnancy? When did the contractions start? Kind of get an idea of the like you sit there and you start talking to them, and if they're talking just like this to you through the contraction, she might tell you they're 10s. These contractions are 10s, but in your assessment, you're assessing, okay, but she's able to talk through them. So my guess is she's in more of an early labor. Maybe she's like 4 centimeters, 5 centimeters, but she doesn't appear to need to be pushing right now. Sorry, just one second. Okay, good. What is your current pain level? Okay. Are we into our next? Okay, so that's a good one, Amanda, asking what is your pain level? I misread that at first. I was thinking, asking her, you're going to get into this though, but asking her what her plan is for, does she have a birth plan? What is her plan for pain control during her labor and delivery? It gets you, a lot of people will have, I shouldn't say a lot. There are some that have very specific birth plans, and usually they hand them to you right when they come in. Francesca, you put down effacement. Save that for, we're not going to check her yet. Okay, so the 4 things you want to ask right now are, how often are your contractions occurring? What time they started, and then you could be timing when one starts to the next one starts, or whoever's their labor coach might be able to tell you that. If their bag of water has broke, is it their first pregnancy? And just because you know that their labor is going to be a little longer, typically, not always true. And has your water broke? So, oh, how many, when is your due date? Those are kind of the 4 questions. So due date, water broke, is this your first pregnancy? And when did your contractions start and how long are they lasting? So now DH's contractions are 2 to 3 minutes apart and are lasting 45 seconds. Pretty good. It is her 3rd pregnancy. So gravida 3, but what, para 2. So that para 2002, what is that telling us? Do you remember? So she's a gravida 2, meaning she's had two deliveries. Okay, 2 babies.
2 preterm.
They're not preterm though. If that would be the gravida 2, para 2 is normal term babies. If they would have been a pretermer, it would be, there would be a 1 or something in that mix. So 2102, meaning that she had 1 pretermer but she still has 2 living kids. All right. And you guys will see this. I was telling my students in clinical that you'll see this written in different variations, quite honestly, depending on where the person probably got their schooling, how old the doctor is, but things will be written a little differently. But basically, it's a way of telling if they've had preterm babies, spontaneous ABs, or therapeutic ABs, and if those, if their pregnancies, if those babies are still alive. So before performing a vag exam, you need to ask DH additional information. What information do you think you want to know? So Whitney said, I want to know if her water was broken. That's good. Hopefully we knew that from the top. You're going to explain the procedure and get a verbal consent from her. Pain level, yes. Birthing plan, yes. You're going to assess any kind of cultural request. If this is a client or a mom that does not want, you can't have, they're very private, they're very modest, they want to be covered during everything, then you have to understand that, and you can't just pull back the blankets and do a vag exam on her. So did you have any complications on other deliveries? What are her vital signs? Any allergies to latex? Good. All of these are really good. So so the consent for the exam is something that we'll kind of narrow in on. But we are in, when did your contractions really start? Do you have any allergies? You guys put that. Any other risk factors? I don't know that the patient would know that, but sometimes they'll know that they've had high blood pressure, and they've been home on bed rest, or they're gestational diabetics and they take insulin, you know, that kind of stuff. In any kind of leaking membranes. I have to tell you though, now if this went on when I was doing labor and delivery, I would have just done a vag exam. Okay. Now you'll notice, it's harder to notice that Natividad because they have they have interns and everyone, so the nurses really aren't doing the vag exams as much. But at Memorial, where they don't have the interns, they're really strict on the doctor does the exam, right? Those of you that are at Salinas Valley, you pretty much, that first exam the doctor kind of does, right? Have you seen that?
At Natividad, I had my doctor, or the doctor performed it, and then my nurse ended up performing one a little bit later.
Right. Once the doc does that first exam, you get this initial of what's going on. As long as she's not acting like she's going to push and you need to get the doctor there, you have a little bit of time. The reason why you want to hold off is if this is, well, one, if this is a preterm patient, do not check her, because you're just putting her at a higher risk for infection. If she does have ruptured membranes, you're setting the baby up for infection. So you really kind of step back on this. But eventually, yes, she has to have her bag of wire broke, and knowing that she's a gravida 3 para 2, and you know she's termed, she's 39 weeks, all of those things, I would go on more the side of doing a vag exam, as long as I felt like all of these other questions were answered okay. The next one, what assessment should you make to gain further information from her? Alex said a pain assessment, cultural assessment, head to toe. Good, Alex, head to toe is important. I know this mom is probably huffing and puffing, and you're like thinking, I got to get the delivery table out, but you also have to take some time. You need to make sure from head to toe what is going on with this mom. How does her lungs sound? What does her pulse feel like? What is her blood pressure? When was the last time she voided? Has she been having diarrhea for 3 days? I mean, all of these things are important to understand how you're going to take care of her. I know people are putting consent to do the exam. Yes, I would say, in my head, I'm thinking, of course you verbally are going to say, I'm going to go ahead and do a vag exam. Is that okay? That, of course, you always do. There is a certain point, though, that when they come into the hospital, they sign a consent that is kind of a global consent to cover you if this mom is out of control and you can't get her to acknowledge anything, but you know you have to do an exam. Maybe the baby's having D cells, or you see the head right there. You're going to do the exam. You're not going to wait. I know that might sound really forceful, but that's a far and few between type patient. But there may be a time where you ask her and she's telling you, she doesn't even give you an answer. Let's put it that way. So, okay. So we have putting the fetal heart rate monitor on. Yep, that's important to know. I like to ask them how much has the baby been moving. If they have had amniotic fluid coming out, what color is it? And since the bag of water broke, if it did, has the baby moved? All of those things. Good, you guys are on it. Look at all of this stuff. So in you guys have a ton more. What they have, that the nurse should note the gestational age, the contraction pattern, and then you're getting the cervical dilatation and effacement and presentation. So you want to make sure that you go to what was I going to say? So going back to what we talked about in the PowerPoint, you know that this is a mom that's a multip. So you might you know that she doesn't have to start from 0 or a dimple. She could start at 2. So you check her and she's 2 to 3 and 60% efface. To me, that's someone who's probably not in active labor yet, because she's a multip. She might be getting there, but these 2 to 3 minute or contractions could also be from dehydration. So there's lots of things that you're assessing, and that's why it's really good you guys are thinking all of this stuff, right? Because it'll give you a better picture of what's going on. So on exam, though, she's 4 cms and 80% effaced. She's in labor. The fetal heart rate is 150 and regular. She's admitted to the L&D unit. And what nursing measures are you going to do at this time? So Claudio said, put the fetal monitor on her. You probably, Claudia, although this is all happening in real time, you probably already have it on her, but, and then good. Also educating the mom and finding out what her birth plan is. Mara Cruz, you said non-pharmacological interventions. What's your idea for that? What are you thinking? Mara Cruz?
Yes.
What do you think? What are you
Sorry,
thinking for
I was mute. Like, for example, helping her how to cope like with pain, breathing techniques, reposition frequently.
Awesome. Yes. Yes. Massage. Maybe we used to be able to let them get up to, in the early days at Memorial, they had the jacuzzi tubs. So we could actually get the tub full with the jets going and let them go sit in the tub. Or some moms will want to go sit in the shower. Hydrotherapy kind of stuff early on is really nice and it relaxes mom. And again, when you relax her, everything, just her whole body is going to work better. The labor process is going to go smoother. You do have to pay attention though, that is her baby of water broken and how the baby looks on the monitor before you do too much with her off the monitor. What's that?
Do they still do like water deliveries? I noticed that most hospitals now have like their tub room filled with just overstock of supplies. And maybe only places like Sutter, like specific maternity hospitals.
Yeah.
Like the water births. Do you know anything more about that?
I know as a labor nurse, I hated to be involved with them because it's messy. Let me tell you. And not to throw a wrench in it, but the labor, the natural birthing process is this baby delivers into an environment that helps expand its lungs. It cries, it pushes that fluid out of the lungs. And that's the whole purpose of doing this, doing this delivery. But that being said, there are studies, it doesn't show that it hurts the baby at all. And I actually had one of my friends a few years ago delivered in the tub kind of thing, and it was fine. But you're right, Shannon. I want to say it's Memorial that has the blow up tubs. I don't think it was Natividad. Does anyone know who's at Memorial? I thought I was told they have the blow up tubs, but you have to pretty much know, like, right when the mom comes in, she has to tell you, my plan is to do a water delivery and so that you can get this tub ready and everything. Jonathan is going, I don't see that. Yeah, but again, to each his own. We have to not put other people in our boxes. So you have to be open for this. I just, Shannon, have you ever seen one?
No, but like you said, I heard that they're very messy.
Yeah, like you need gloves like up to here and goggles and yeah, it's.
My sister-in-law had one a couple years ago.
Did she? How'd it go?
She loved it. She thought it was
really
incredible. Yeah.
But Brittany, you didn't go that way, huh?
I don't have kids.
Oh, I thought you did. I'm sorry.
No,
I'm thinking Grace. I'm sorry.
Oh no.
Would you do it, Brittany? Do you think?
I've actually considered it. Yeah, I like the more natural, like homeopathic versions. But again, I have no idea until I'm there,
right,
experiencing it. So,
yeah. I mean, anything. If I guess you think about what helps you relax. If to me that would make me more on edge to be in a tub, and you know what I mean. That would not be something for me. But yeah, like you said, it might work for other people who are very comfortable doing that. Let's see. So our next question is, as a part of your assessment, you review the fetal heart rate strip here. Based on these findings, what's your intervention? Are they late what do you think they are? First of all,
late decelerations.
So you're, let's see, yeah, they are, well. I don't know that I would, let's see. Yeah, you know why I'm not gonna call them lates? So a late is, see this peak right here? Right here. This heart, the baby's heart rate would start going down right there. So it would be more like this. Okay. This one is probably cord compression. Honestly, it's hard to tell, but right now the strip is still okay. If now, I mean, you'd like to see it a little more active, and as far as we used to call it, I think they still call it variability, but it's okay. But I can see, was that Brittany that said it was late?
Yeah.
It has a little bit of a look as far as the shape of a late, but actually where it comes in the contraction, it's an early. Okay.
Okay.
So what stage of labor do you think she's in? So if you're thinking first, second, etc., what stage? Good. Vanessa, you put first stage. Yeah. She's in the first stage of labor. Good. So now they ask you to list the stages of labor. Good, guys. Okay. So I've seen this as an exam question before. So here they breaking apart the first stage into the latent, active, and transition. And then the second stage is, yes, full dilatation to in the pushing part. And then the third stage is actually delivering the baby. Fourth stage is the placenta. Good. How long, sorry, let me go back here. Wait, we need to fix this a little bit here. Second stage, full dilatation to pushing. Let me just make sure I have it right for you guys. To the birth of the infant. Let's just add, let me add this. Okay. And then this one, this is actually okay. And then this one is actually a little different too. So it's basically up to 2 hours. Where did I put that? Okay. I guess you'd put something like after delivery of placenta to 2 hours post. Does that make sense? Does that make sense, you guys?
Is that in regards to the mother care, like stable, like
this fourth?
Yeah, the fourth one, the fourth stage. Is that what you're talking about? 2 hour post?
Yeah. Yeah. Yeah, it would be in relation more to mom. Exactly. How long does labor last?
Until the baby's out.
So if this is her third baby, they already said if this was her third baby, it's what are you thinking?
Well, I mean, it can still be different. Sorry, it can still be different because the other day I had a patient who it was her 5th delivery and it was her longest labor.
We actually had a patient that ended up with a C-section on her 5th delivery. I was like, oh. But yes, you're correct. But typically the multi mom will go faster. So like if you roughly someone put the first stage of labor lasts around 12 to 19 hours. Yeah, Nick, I would say that's a good kind of point, usually for a first-time mom. Hopefully with your second baby, it can be half that. I usually ask moms, how long did your first labor last? And if they tell me, oh my gosh, it was like 24 hours. Well, one, it probably wasn't 24 hours, but the other is this will be shorter, and you can tell them, okay, well, typically your labor should be about half as much this time as, you know, and that kind of makes them relax a little more, right? So DH says she's feeling increasing discomfort and asking whether there is alternative therapy available before taking her medication. What 4 alternative methods for controlling her pain can you offer her?
Maybe like counter pressure.
Good. Selena, in the PowerPoint, it goes more into this deep breathing. So there's like relaxation breath that you encourage them to do every so often. But as she's getting more uncomfortable and maybe she's not feeling like she wants to have pain med yet, you really look at doing more of a pattern breathing with them. In the slides, it has a little more on that on the pain PowerPoint. It talks about different types of breathing. You can have them just practice doing this in and out in kind of this imagery while you're showing them basically what they're going to do. And then you may have to progress to maybe a change. Maybe you have them take a relaxation. They're doing this real in and out. And then at the peak of the contraction, they really feel like now they're feeling like they have to push. You don't want them pushing because they're only 4. So you might have them concentrate on doing little puffs, you know, okay, just to keep them from pushing. And the coach with them can give them different signals as far as they can come up with a pattern. Like, okay, take your relaxation breath, breathe normal. Okay, as it's going up, remember, don't do your little puffs, you know, do 3 puffs or do 4 puffs. And it keeps the person focused, relaxed, because they're focused on something else. And then at the end of the contraction, doing the big relaxation breath, knowing that now this is the time the baby's getting all of that great oxygen, okay? Changing positions, audio therapy, yes. We used, I know for myself, I used music during mine. Changing positions, using lots of pillows. Yes, there's the peanut ball, which is, for those of you who don't know what it is, you can look it up. I think there's probably some pictures of it, I think in ATI, but it's basically a huge ball, blow up ball that looks like a peanut, okay? And you can get mom in different positions. They can actually stay on that and use that through the whole delivery, labor and delivery. Let's see, what else? Aromatherapy, good. Soothing music, back rubs, dimming the lights, yes. And having a visitor. When we first started this COVID and they weren't letting the coach, the significant other, in for this delivery, I don't know how these women did it. That, you know, I mean, personally for me, I chose only to have my husband in there, but that's huge to not have someone in there with you that's for you, right? Any comments on that? No? So here, as you assess, both DH and the fetus during the active stage of labor, you will monitor for potential abnormalities. Identify which potential abnormality you may encounter in this assessment. So Claudia, you put unusual bleeding and sudden severe pain, brown greenish amniotic fluid, and there is one more. What about this one? Oops, I don't know how to make it a color, but yeah.
Would it be the deceleration of the fetal heart rate?
Yes.
Yeah.
Go ahead and do that one. Yep.
Thank you.
The contractions that are lasting 40 to 70 seconds are normal, right? I mean, at this stage, as she's in active stage of labor, you really need them to be lasting at least 40 to 70. Just because the baby's not going to come out with short contractions. It's just not going to push the baby out. So an increased maternal fatigue, well, it's not really abnormal. She's doing I tell these moms, you know, it's the hardest thing, the hardest workout you've ever done. So they are going to be fatigued. Okay. So although DH continues to use alternative therapies for discomfort, she asks for pain medication and receives a dose of Demerol. She is also placed on oxytocin for infusion. That we would use now. Have you guys seen other choices? Well, now a lot of them are getting epidurals, but if you were going to go give them something IV push, what do you think they would give? Well, take a look, think about if how do I want to put this? Think about what Demerol might do to the baby.
Is it fentanyl?
Yeah, fentanyl. I would think nowadays they're going to use fentanyl. In my time, we were giving promethazine and Demerol IV push. Do you give promethazine IV push any longer? Promethazine is Phenergan, and we no longer give it. If somebody orders it IV push, it's a no, you don't do it. So we said fentanyl would be probably 100 mics, 50 to 100 mics of fentanyl. She can have that every 1 to 2 hours usually. It's very fast acting, but it also goes away pretty fast. So sometimes it's a good medication if you have a multip that she doesn't really want an epidural, but she's getting close to delivery. Fentanyl would be a great option because it doesn't affect the baby really as much. Okay. Any other questions? What is the purpose of giving the oxytocin?
Stimulate contractions.
Yes. David, yes. Okay. Let me get anything else to increase her. It's not really, you got it's mainly for contractions. So 3 hours later, DH is lying on her back, and her contractions, you notice a few of them are late. You stay with DH to monitor her and the fetus and immediately call for someone to notify the primary care provider. What in this here is a red flag? And it's not the late decels.
She's on her back.
Yes. Yes. Do you think that if I put her on her side that could help resolve the lates?
Potentially, yes.
Yeah, potentially, you're right. So put these actions in order of priority. And honestly, I kind of went around with this with another instructor, the way they had this, but the first thing I would do would put her on her left side in elevator. I don't know about elevator legs. I would put her on her left side. And then I would DC the oxytocin, but we went around and around. So what did they put here? Let's see. So if you put her, so I'm going by the thing that she's having the late decels possibly because she's flat on her back. So I would turn her to her left side. I don't know about elevator legs, but I would turn her out to her left side, maybe put a pillow between her legs. I would increase her IV fluid and turn off the oxytocin. Kind of all at the same time, and put her on some O2. You kind of are almost doing this all at the same time. So I'm having a hard time deciding what to tell you, because the other instructor was like, no, I would turn off the oxytocin. So since this is something that you know you're going to do, because we're not going to keep giving her medication that are causing contractions that is making the blood supply and the oxygenation to the baby worse, right? Because we're giving her contractions that's compressing the placenta and causing the baby not to have oxygenation during those contractions. So if you think of it that way, yes, then we would turn off the oxytocin. Then almost at the same time, turn her to her left side. Left is better. And increasing her IV fluids is just gonna, this would probably be fourth. Claudia put it fourth. Put on some oxygen and then increase her IV fluids. When you watch nurses do this, it really is almost all at the same time, okay? But so if this was a test question, I guess I would have to call the first one would be DC the oxytocin. Second one, turn her on her left side, put some oxygen on her, and then increase the IV rate. I guess that would be the way I would do it. So the decelerations occur in an early, variable, or late pattern. What significance of these patterns? What is the significance of they? State what the nurse should do for each type. So Loida said early decels may be caused by head compression, are considered to be harmless. Okay, good. Variable decels can indicate cord compression. You can reposition her and keep monitoring her. Turn up her IV. If they get really severe, you might want to have her on oxygen. Hopefully delivery is imminent. So it's not one of those things, because if this was a 2 centimeter primip and she was doing this, the baby's not going to last having severe variables for hours. You just can't have that happen. So it just depends on where she's at in labor. But late D cells are considered more urgent. And if it's indicating that the baby is not getting the oxygenation perfusion that they need, and something needs to be done. Now you'll see docs watching monitor strips that have some late D cells, but there might be 1 or 2 in a row, and then the baby does okay, and they kind of continue to watch her. But anytime it becomes consistent, in my head, I always think 3 in a row. When you get 3, 4 in a row, if you've done all of this other stuff, turning up the IV, turn off the Pitocin, have her on oxygen, and she's still having these, this baby needs to come out, okay? As you monitor DH, you observe the signs of the umbilical cord prolapse, Describe what can happen to this fetus. So Jasmine, you said, it's when the cord drops between the fetal presenting part and the cervix, good, into the vagina. Due to this, the cord can compress and squeeze and deprive the infant of oxygen, which can cause death. Correct. That being said, sorry. Sometimes you don't feel the cord. You just know that mom was fine. Maybe she had just gotten up to the bathroom. Yes, her bag of water maybe broke in the bathroom, or she'd been getting up, and now all of a sudden you have the fetal heart rate has just bottomed out, and there's nothing you can do to get it back up. You have your hand in there, you don't really feel a cord, but you basically keep your hand in there and try to keep that presenting part up, off, and it's an emergency. The baby's got to get out. So describe what interventions you're going to do. I just said, so you're going to call, it's a stat emergency, okay? All hands on deck. You don't take your hand out of there. What other thing can you do? Who wrote this? Abram wrote this. So no, stay with the client, keep your hand in there. If you had your hand in there while this was happening, it doesn't matter if you don't feel anything, keep your hand in there, trying to push the presenting part up, flip her to knee chest position. And why do you think that's going to help?
Doesn't it keep the pressure off of the umbilical cord?
Yeah, so when you think about it, so when she was on her back or on her side, you just have more bony structures, right, that are pushing as the uterus is contracting, the baby's pushing against those bony prominences. If you turn her to her knee chest, all of that pressure kind of comes down, right? So at least you're hoping, really, you're doing what they call a Hail Mary. You're trying to get her in a position that takes the pressure off the cord. That's your goal. As far as a vaginal delivery, it's not an option. The only way I could see this being an option for a vaginal birth is if the head was coming out right now. Like the baby, this happened, you turned her over, you see the baby and you deliver the baby. That's the only way a vaginal birth is going to be an option. Because the baby will die before, okay? Yes, putting her on oxygen. You try extremely hard to keep the fetal heart rate monitor on. Usually at this point, you would have stuck on, during all of this, with your spare hand, you would try to put a fetal scalp lead on so you can keep better track. But the most important thing is to get the baby out, okay? There is no oxygen going to the baby any longer if the cord is totally compressed. So the decelerations and the rest of labor is uneventful. That would be an eventful right there. So let me tell you, my blood pressure would be up. And so they kind of act like, let's see. As you monitor.
Sorry to interrupt. David in the chat just said some of us have to go to skills lab now. Thank you and have a good day. It's 1 o'clock.
Oh, I'm sorry. I'm blabbing on. I'm sorry. Yes, sorry. Okay. Let me just see on the rest of this. I'm telling you, just back up here. This would be extremely unusual for this to end up a vaginal delivery. I'm sorry. I'm going to let you guys go. I know. I'm getting, they're 10 minutes past 32.
Are we turning this in?
Yes. You know what I'm going to do is I will go through. Thank God Alfredo says. I'm going to give everybody who inputted and was part of this discussion, you're getting credit for this case study. Okay. Now, I do want you to go, we didn't get to do the CRS one, but complete the CRS and turn that in as a group, right? So you guys should have
want
all.
that to be color coded according to who did what, or do you just want it all in black so it's not?
No, I think that would be helpful to have it color coded. I mean, I'm not into, unless it seems to be a pattern where, wow, someone did this whole thing and nobody else had input on it, then I'm going to ask questions in the group what happened. Okay.
Ms. Thorpe, what if we already submitted it? So our names are on top.
You already submitted it and you didn't do it, Alfredo? Don't worry about it.
No, I did it. I'm just saying we submitted it already.
Oh, no, I saw that. That's why I really liked it, but that's when I realized I didn't really tell you how CRS ones go. So no, yours looked great. Yours was good. Okay.
Ms. Thorpe, Ms. Thorpe, for my group, we submitted already. We collaborated together and we put the names on the top, but we made it one color. But it's been submitted since I think like yesterday or the day before.
Was that Claudia? Because I only saw one that was submitted. I thought it was.
It has the names on the top, but I'll double check.
Okay. All right. So just as we move forward, just know I do prefer the color so that we can see who did what. Okay.
All right. Sounds good.
All right. Thank you, everybody. Sorry I took you too late. I get going and you're going to have to set a timer for me. Okay.
It's all right. Have a great weekend.
You too. Have a great day. Bye.
I'll volunteer to be your timer for next time if you're comfortable with that.
I'm totally comfortable, Kelly, because I'm like looking at 3 different screens and it's like, you know, so no, I want to respect your guys' time. So
I also want to say that I really enjoyed doing the case study all together. I feel like I learned more this way with your kind of guidance and input as we went.
Awesome. Thank you.
So
thanks. That was actually a suggestion from Emily. She said, yeah, she said, we really prefer if you're going to give us a case study to do it together kind of thing. So
yeah, absolutely. Perfect. Well then,
thank you.
Well then, thanks, Emily.
Thanks, guys. Okay, I'll talk to you later. Bye.